All right. So we get started with the live transmission from Dr. Sivakumar doing an ASD closure. Siva, can you see us? Can
Yes,
you hear us?
I can hear you very well, Mario. I
Great.
saw Ahmed sitting with you. Who are the other panelists?
The other panelists, well, I have Tin here, and
Oh,
then
Tin.
Ziad Ijazi, Ahmed Chalebi, and Gitsil Sudis.
Oh, okay, great. Tin, good evening to you, and Ziad, good evening. So this is a patient who is having an atrial septal defect. Can I have the PowerPoint running? Yeah. So this is a 21-year-old lady who was recently diagnosed to have a large secondum ASD. She had history of exertional palpitations. She was on some medications for polycystic ovarian disease, but heart problem was not identified in the past. About a year ago, she had a treatment of anti-tuberculosis therapy for extrapulmonary tuberculosis when there was an increased bronchovascular markings noted on the chest X-ray, which led to a CT scan. The CT scan showed multiple mediastinal lymph nodes, and those lymph nodes then subsequently were identified to be possible to be tuberculosis, and she was treated with tuberculosis because of some serology tests. Retrospectively, whether that increased bronchovascular markings were actually due to ASD is also another thought. The patient is having features of secondum ASD with wide fixed split and an ejection flow murmur in the pulmonary area. Next slide. This is the chest X-ray showing mild cardiac enlargement. The MPS segment is dilated. Central pulmonary arteries are dilated. The hilum is looking prominent. ECG shows nothing remarkable. It's the usual ECG. Next. So this is the transesophageal echocardiogram. So the transesophageal echocardiogram shows a centrally located secondum atrial septal defect. This was measuring 20 millimeter, rather circular, 20 to 21 millimeter, rather circular in all the planes. So this is at 0 degree, 45 degree, and 90 degree. In all the views, it was around 20 millimeter. And next slide. So this is the 3D en-face view from the right atrial view. We are able to see that secondum atrial septal defect, which was centrally located. Next picture. So the plan is to do a transcatheter AST device closure. This is a 20 millimeter AST device, so we are going to be using a 24 millimeter cocoon device. The cocoon device is basically something similar to an Amplatzer septal occluder, but the difference is that there is a nano platinum coating on the surface of the AST device that prevents a nickel leaching, and so this is supposed to reduce the serum nickel levels, and there were some studies that were done in Thailand, which was the primary origin of this particular product. So what we have got is right now a right femoral venous access and an arterial access for just pressures, so that we will know what is the blood pressure. Open the pressure line. Open the pressure line. Now, already my colleague Dr. Raghuram, who has done the cardiac, the punctures, he took the catheter into the right pulmonary, into the pulmonary artery, and found that the PA pressures are normal. Can you give me a guide wire? Any questions, Mario? It's a centrally located 20 millimeter secondum ASD, which
looks like a straightforward case, I would say.
Exactly. Yes. So my guide wire is going into the, now I'm advancing it. So already the catheter has gone into the left atrium. So now what we are going to do is advance the guide wire into the pulmonary vein.
So Sivakumar,
yes.
Do you do full hemodynamics with ASD closure, or you just, this is a young...
No, we recorded the pulmonary artery pressures. The pressures were normal, and the
about the sat run.
Sat run we don't do at all. There is evidence of right atrium, right ventricle enlargement with a normal pulmonary artery pressure, and the echocardiogram showed a large left-right shunt. So we don't do oximetry. Do we do them in every routine case? We do it only when it is pulmonary hypertensive.
Every ASD I do.
Okay, I ensure that I always check the.
You know, we get data. That we use it for. First of all, we calculate PVR and all of this, and knowing that certain in such patients is going to be normal. But for publications and all of that, when you have full data, you have it. But you can't go back and say, well, yeah, the data was this and that.
Well, actually, we don't do routinely unless that's an old patient or something, pulmonary hypertension, etc. Because in a straightforward young patient with ASD, you decided the indication for closure before taking the patient to the cath lab.
I agree with you. I think it's not a matter of right or wrong here. It's basically a practice. And in our lab, in my hands, not our lab, not all my colleagues do this. And I just get all the data that I need, and then I proceed with the closure.
Well, we can make this question to anybody, to the panelists, routine, and to the audience. Who is going to do a routine hemodynamic measurements before closing the ASDs?
Raise of hands.
Very few.
Very few.
Anyway.
I agree with Ziad's point that it can be a data collection exercise wherein we will have a data at the end of many years about all the QPQS of every patient. But then does it have any big scientific implication to know that there is a 2:1 shunt or a 1.8:1 shunt? I'm not very sure. But what we do is in every patient who is hypertensive, pulmonary artery systolic pressure is more than 50 millimeters of mercury, I invariably do it. Now,
I mean, the other thing for educational, when you have fellows in the cath lab, I think it's important to teach them things from the beginning rather than just, okay, here is a hole, normal peer pressure, just go and close it.
Siva, you already advanced the long sheet in the left atrium, we see.
Yes.
Can you tell why you decided to use the 24 millimeters cocoon, no balloon size, no nothing?
Yeah.
What's the criteria for you to select this plan?
Yeah, so this is a 20 millimeter atrial septal defect which is having a good margin all around. The margins looked reasonably sturdy on the transesophageal echocardiogram. Just to go back to the PowerPoint once. Go back to the PowerPoint, please. Go back to the PowerPoint and show that transesophageal echo picture.
Yeah, we saw the echo on the PowerPoint. But my question is, this ASD with the size not so big, the rim is enough, the central hole, and I think it's not a complicated case for you. But what you want to show everybody, the special technique or something special for everybody?
Actually, in this particular patient, the ASD is too centrally located. So I feel that in a very conventional way, if I do, just get one transthoracic echocardiogram apical 4-chamber view. So what we do is, in a very uncomplicated atrial septal defect, we try to keep it very simple. So that means I will be doing the procedure with minimal sedation and only groin venous access. No advanced echocardiography except transthoracic echocardiogram. So now you show the echocardiogram there.
Yeah, just another question. You measure the maximum size 20, 21,
yes.
Right?
Yeah, 20 to 21.
24. So this your common practice to oversize the device 2 to 4 millimeters?
Yeah, 4 millimeter. If the patient is too small, then I will oversize by maybe 2 millimeter or so. Like for example, a very young child, I will oversize by 2 millimeter. She is a relatively grown-up patient, so this is 4 millimeters we are. Now, Dr. Rupesh is now showing you a thoracic apical 4-chamber view, where he is showing the sheath across the left atrium. So now what we are going to do is, Rupesh, your hands out.
Is there any case where you do balloon sizing?
We do balloon sizing only in patients when there is multiple atrial septal defects, where I try to go through one of the orifices, do a balloon occlusion to occlude that ASD, and then take the second venous access so that I cross the additional ASD. That is one indication. Second indication, in patients where there is a suspicion of a restrictive LV physiology, I try to see balloon occlusion and try to see what is the LV end diastolic pressure elevation. The third indication, in patients who are having pulmonary hypertension, after doing the regular hemodynamic study with oximetry and assessing the QPQS and PVR, SVR, Then I do a nitric oxide study with oxygen and see whether they are responding. And before closing that ASD, either with a fenestrated device or a regular device, I will do a balloon occlusion and put in a catheter into the pulmonary artery to see what is the pulmonary artery pressure and whether it is reducing or not. So these are the 3 cases where I will do a balloon sizing. This is in a regular atrial septal defect. There are also some other atrial septal defects where I will do a balloon testing. If the patient is having a borderline hypoplasia of the right ventricle, for example, a patient is having borderline hypoplasia of the tricuspid valve, right ventricular outflow obstruction, or pulmonary valve narrowing minimal, and in such patients where there is some borderline right ventricular hypoplasia, where the right atrial pressure may be expected to increase if we close the ASD, I will do a balloon occlusion and check what is the RA pressure. So this all will be one of the classical indication of that. The last subset that I told will be a newborn who is getting a balloon pulmonary valvotomy for a critical pulmonary stenosis or a pulmonary atresia with intact ventricular septum, where we perforate and do a BPV. Subsequently, the patient comes at around 5 years or 6 years of age with a persistent ASD which is bidirectionally flowing, maybe marginal occasional desaturations to 92 degree, 93 degree. In such cases, we go and balloon occlude that ASD, check the RA pressures, and if the RA pressures are good, we go ahead and close it. So these are some of the select indications,
these,
not for assessing a routine ASD.
Yeah, all these reasons are motivated by physiological complexity more than anatomical decision about the size of the device, correct?
Exactly. So now what we have done is, I have deployed the LA disc. Now Dr. Rupesh will show the echocardiogram. I'm going to bring the...
Siva, this is Ahmed. Do you use color flow diameter in deciding of the device?
No, it is 2D edge to edge diameter. We don't use color. So now I am not doing fluoroscopy. I'm just coming closer and closer to the atrial septal defect on the moment I come pretty close. Now take the hands out. I will now see one fluoroscopic picture and record it for you. Okay, now go to parasternal short axis. So Dr. Rupesh is now showing.
Yes.
Dr. Rupesh is now showing a parasternal short axis view.
Yeah, I think so it's very useful because the sleep and the device is sleep in the aortic rim.
Exactly. So now what I am going to do is, take your hands out. So at this position, I am going to slowly peel back my sheath, and
so you are using fluoro.
So now the device,
it's not sitting right.
It's not sitting right because the aortic margin has not caught well. Now show the parasternal short axis.
Because
can you
echo,
us simultaneously
Sivakumar,
yes,
fluoro and echo, please?
The transthoracic echo that your colleague did showed the device was prolapsing already into the right atrium.
Yeah. Now I will now readjust it. Now you see that this is the parasternal short axis which is showing the prolapse. Now I will readjust it. Take your hands out. So now I am going to recapture the right atrium. Now I am recapturing part. I am giving a rightward clockwise torque for the entire device. To make it
go to right upper pulmonary vein.
Not necessarily the right upper pulmonary vein, but try to keep it in the right side of the left atrium.
Yes.
Now, can you show me parasternal short axis? Run this for fluorostor once again. Okay.
So let me ask you one question.
Is
there a situation you would change the sheath to a steerable sheath?
I mean, basically, I have now used in fact, this is not even a delivery system. I have used a Cook-Mullin sheath. Okay, now take your hands out. So I am now going to deploy the RA disc. Okay.
That's it.
Now fluorostore this. Run this fluoro. Now show me the transthoracic echocardiogram. So first he will start with an apical 4-chamber view. So this is an apical 4-chamber view that shows magnify that device with the mitral margin. Yeah, magnify that. Yeah. So demonstrate the thin mitral margin that is going in between. Color now. So Rupesh is our final year fellow, one of the very brilliant guys in my department, and he is now showing the mitral margin getting inside the device. Now show Rupesh the parasternal short axis. Invert. Yeah. Keep the device in the center. Yeah. Now go on a mag on the aorta and the device. Yeah. It looks beautiful. Let me see once. So this is the parasternal short axis view. So now what we are seeing is the little bit of flaring, the small aortic margin that has got inside. So the device looks satisfactory here. The second one will be apical 4-chamber view. Take the okay. Now go on a mag. Yeah, that's a good picture. So this is the mitral margin entering inside. Now the last one, get me some more jelly. Okay, I'm going to go subxiphoid. Now, yeah, make a zoom on that. Yeah, correct. That is the right upper pulmonary vein. Color the right upper pulmonary vein. Color is not penetrating much because of the subxiphoid. Can you increase the color gains and reduce the color scales? No, not so much. Okay, but okay, without color you show the 2D. Now I'll try to get a good quality. Make the distal gains higher. Color now. So that is the superior vena cava color. That's the superior vena cava color, and this is the ASD. Okay, now I'm going on a subxiphoid coronal sweep. The position looks good. So now, Dr. Raghu, can you do a wiggle? So just, no, don't do fluoro. Don't do fluoro. You have to pull slowly. Enough. That's enough. Now do a color. Okay. So just stay there. Don't release it. I'm going on a parasternal short axis. Invert. Okay. Color. Magnify that area. Okay. Give back the pull that you have given. Give it back. Correct. So it looks good. Now I will do a regular Minnesota wiggle and on fluoroscopy.
So you did that on fluoro, on echo, sorry, and you repeat on fluoro? Is that
Yeah, I'm going to repeat on fluoro. I'll do it now because at the time I was, okay. So now,
yeah, looks very stable.
Look stable. Once
So
again,
patient,
check on echocardiography.
the patient is still under
Little
mild sedation.
Little bit of sedation, yeah.
Okay.
Just to keep her without anxiety. That is a blood pressure. I don't know whether you are seeing the hemodynamics also. Can you?
I mean, Sivakumar, I mean, I know that sedation, I know that ice is expensive in India and the rest of the world. But one way to get away without sedation, without any anesthesia, is ice. Intracardiac echo is very effective tool to show you everything that you need to show.
True.
And maybe
I fully
young patient, the transthoracic echo is satisfactory, but maybe you may come across some patients where the transthoracic echo is very poor.
That's right.
So in that case, I don't think you can avoid to use transesophageal echo. What do you think? Well, at least we do transesophageal routinely,
Yeah.
or eyes. But I mean, it depends from patient to patient, I would say.
We
Yeah,
don't, unfortunately, we don't have eyes. I'm sorry. We have.
You don't have eyes.
No, we do a transesophageal.
Ahmed?
you do always transthoracic echocardiography, always those patients have complex ASDs such as multifaceted and also poor echogenicity, especially in older young patients. We always prefer transesophageal echocardiography. Poor echogenicity.
In what you do?
For example.
Yeah, for simple case, we do just a trunk thoracic. Just some complicated case, we use a TE.
I use eyes. Exclusive.
You are able to see the pictures, Tin?
Yeah.
This is the parasternal
can
short
see.
axis that I'm showing with the inferior vena cava color flow, and that is the right lower pulmonary vein behind the device. This is the device position. I'm going to go for an apical 4-chamber.
Just Sivakumar, questions aside from the closure itself, in terms of heparin, how much do you give? Do you follow ACT? What's the practice in your lab?
Yeah, we give 100 units per kilogram body weight of heparin. In this particular patient, we give 5,000 heparin. And then the second thing, magnify. The second thing is no ACT was done because the puncture was made just about 20 minutes before, and we will be taking it out now. No further ACTs will be done. About the antiplatelets, I will be giving her aspirin. Actually, she received aspirin yesterday, so she will continue to receive aspirin once a day, 150 milligram daily. This is about the antiplatelet. About the periprocedural antibiotic, we give 1 dose of cefuroxime, which is second generation cephalosporin. Color.
So Sivakumar, so the antiplatelets, you only give aspirin in adult patients. You don't do dual antiplatelets.
If the device is large, measuring more than 30 millimeter, I give dual antiplatelet. If the patient is having multiple atrial septal defect, I give dual antiplatelet. If the patient is having coronary atherosclerosis, dual antiplatelet. Otherwise, any device that is less than 30 millimeter, single antiplatelet. All children, single antiplatelet.
Well, we are using just aspirin for 6 months.
Yeah.
That's it.
Even adults.
Yes.
And you have not had patients complaining of weird headaches, migraines after a closure?
It's
I
quite.
think the reason we switched to dual in adults over the age of, like, say 14 years of age is because of that paper from Mark Riesman, where about 10% of patients complain of weird headaches. And once you start these patients on dual antiplatelets, these headaches, they disappear.
What is the reason for that?
Nobody, well, the theory that, serotonin release and these devices, have clots, thrombosis on the device that will release serotonin and produces headaches.
Well,
Actually, Z, can I add a point? Z, one thing is, in our countries, we have got different devices. Like, for example, this Cocoon has got a nano platinum coating which reduces the nickel leaching and possibly reduces the platelet addition onto the device that leads to secondary platelet related mediators that go into the circulation and then cause these headaches. So we use LifeTech device, which is titanium nitride coated. We use Cocoon device, which is nano platinum coated. So probably the incidence of headaches may be marginally be less in these coated devices. What do you think is your thought on that, Z?
Well, I mean, you could be right. We don't know the exact reasons, but from experience, I can tell you that patients, when we use the Amplatzer or the occlutic devices, definitely some patients complain of headaches and they disappear when you have the Plavix added to the aspirin.
Yeah, so one of the paper that was published from Thailand was to study the nickel material, and also some of the inflammatory mediators, some inflammatory molecules that were in circulation at the end of 24 or 48 hours. And this particular this cocoon device, this device has got a nano platinum coating, and so this platinum coating is supposed to little bit reduce like that sort of a mild some inflammatory mediators that may be released from some of the blood cells which adhere to the device surface.
Well, you know, all these are very interesting observations, but I wonder if they are really true, scientifically demonstrated, or just our thoughts. Yeah.
I don't think, to my knowledge, any scientific proof has been done. It's all observations.
But headache is also described in combination with nickel allergy also with these devices.
Actually, this paper on this nickel and the inflammatory mediators on cocoon device was published in the Pediatric Cardiology. It's actually a little older paper. It's almost about 15 years ago, and they demonstrated some of the inflammatory mediators. I think one was high sensitivity C-reactive protein, some markers to show that the subtle inflammation may be little less compared to some other devices. But well, I do agree that we don't know much about it.
A discussion about the nickel allergy, but it is something that I never understood, and I never had a demonstration about that. So that's everybody's talking about nickel allergy, but I implanted nickel devices in several patients with non-nickel allergy, and nothing happened.
I agree with you. I had the same experience.
So Z, thanks for the opportunity for us to transmit to this case. I think you have a few more lecture sessions planned for this session. So yes. I will meet you all tomorrow morning.
So thank you very much.
Thank you. On behalf of the entire team of MADRAS Medical Mission, I thank all of you.
Thank you very much. Thank you.